Dr. Gayatri will start with the presenting case.
Good morning, respected faculty and dear colleagues. To begin with the case, our patient was a 22-year-old migrant worker hailing from Nepal. She was a third gravida, para 2 living 1, presented in 6 months amenorrhea. She was received in the emergency department at AIIMS on 5th December 2022 in an intubated state. She had had history of having 4 episodes of abnormal body movements involving all her limbs associated with uprolling of eyes, frothing and tongue bite. Symptoms beginning since the morning of 4th of December 2022, with each episode lasting around 4 to 5 minutes. There was no prior history of trauma, fever or any similar episodes in the past. No history of raised blood pressure records prior to this episode. No history of pain, abdomen, leaking or bleeding per vaginum. For the above complaints, her first hospital visit was at CHC Baleshwar at 8 a.m. on 5th of December, almost 24 hours after onset of symptoms, where she was detected to have raised blood pressure records and where she again had an episode of seizure. There she was given IV antihypertensive agents, loading dose of magnesium sulfate, IV diazepam, and was referred to a high center. Her first referral center was a district hospital in Burari in Tiri Garhwal on the same day by evening, where she was intubated in view of poor GCS and referred to AIIMS. In her antenatal history, she had no history of antenatal visits in this current pregnancy. Therefore, no blood or radiological investigations were available with her. Moving on to her menstrual history, she was unaware of her exact date of her last menstrual period. However, she was able to tell that her prior cycles were regular. Her obstetric history, she was married for a period of 5 years. Her first pregnancy was 4 years ago, where she gives history of having had raised BP records. However, it was otherwise an uncomplicated pregnancy when she delivered a full-term normal vaginal delivery and had a female baby. However, there was history of early neonatal death on postpartum day 8. The exact cause is not available, as records of her previous medical records were not available to us. Her second childbirth was 3 years back. Again, an uncomplicated pregnancy where she had a normal vaginal delivery at term, where she delivered a female baby who's alive and healthy. This is her third pregnancy, which is spontaneous conception, unsupervised and uninvestigated. There was no significant past or family history. She gave history of occasional consumption of alcohol and cigarette smoking for the last 3 years. On examination and presentation, her GCS score was E3VT-M5. On general physical examination, pallor and icterus was appreciable, no pedal edema. Her vital signs, pulse rate was 72, respiratory rate of 24. Her blood pressure was high, corresponding to 170 over 110 millimeters of mercury, and IV injection labetalol was given to control her BP. She had proteinuria at presentation. Her saturation was 94, maintained at 94% with an FiO2 40% and PEEP 6. On examination of her respiratory system, crepitations were appreciable in the bilateral lower lung fields. Heart sounds were heard normally. On per-abdominal examination, uterus corresponded to 18 weeks gravid uterine size, and on USG examination, fetal cardiac activity was not appreciable, and per vaginal examination showed that the os was closed and there was no leaking or bleeding per vagina. The initial blood investigations that were available at presentation showed thrombocytopenia, counts moderately elevated with slight left shift, AKI and hyperbilirubinemia. So to begin with, what we had, the positive history and findings that we had to work with was an antenatal woman in her second trimester presenting with raised BP, proteinuria, seizures and IUD, and investigations showing thrombocytopenia, AKI and hyperbilirubinemia. So the initial differentials that we placed to work on was antepartum eclampsia with possibility of partial HELP, or whether it was a component of sepsis with MODS. So our initial line of management was along these lines. After admission, the patient was shifted to the critical care unit for further management, where she was started on IV antibiotics, anti-epileptics and supportive care was initiated. POCUS showed left lower lobe consolidation features, otherwise non-significant. Magnesium sulfate was started as seizure prophylaxis by Zostan regimen, and assuming her symptoms to be part of eclampsia-related complications, patient was planned for induction of labor, which was initiated on the same day of admission using misoprostol regimen. Simultaneously, imaging was being done for the patient USG obs scan showed intrauterine fetal demise. Simultaneously, brain imaging was done to rule out organic causes for seizures. NCCT head showed diffuse white matter edema in bilateral cerebral hemispheres and punctate hemorrhages in the parieto-occipital lobe. No other significant findings. Subsequently, a CE MRI and MR venogram was also done, which showed features of breast with microhemorrhages and a normal venography study. The initial cultures available on the day of admission, blood culture was sent on the same day, which later came out to be sterile. Urine culture grew Klebsiella, significant count, sensitive to atropine. Meanwhile, the patient progressed adequately after 2 doses of misoprostol, and she expelled her fetus 24 hours after initiation of induction. It was an uneventful delivery. There was no postpartum hemorrhage and no evidence of retroplacental clot. She delivered a male fetus, 400 grams, delivered NSAC with no gross anomalies, and was a macerated fetus. In view of low platelet count, she was prophylactically at that point given 4 RDP transfusions. Right from the beginning, because this was slightly an atypical presentation to us also, a woman presenting in second trimester with eclampsia, we'd involved a multidisciplinary team right from the beginning. So neurology opinion was taken, and they advised us to continue anti-epileptics. So additional to myself, she was on levetiracetam IV injections. Neurosurgery opinion was sought, and they said that no active intervention was required for the punctate hemorrhages. Ophthalmology did a fundoscopy examination, which was normal. Gastroenterology opinion was sought in view of the deranged liver parameters, and they were of the opinion that it is sepsis related, and we were asked to manage along the lines of sepsis. So the expectation was that post-delivery the patient would improve. However, the course was on the contrary. Patient continued to deteriorate post-delivery. Patient had multiple fever spikes, Tmax up to 1 or 2.5 degree Fahrenheit, along with evidence of worsening liver, kidney parameters, worsening thrombocytopenia, and now new onset anemia in the absence of any active bleed. So additionally, she had an episode of ET bleed, for which additional RDP transfusion was done, and ET tube was required to be changed once in view of partial obstruction. Further imaging and HRCT chest was done, which showed evidence of confluent consolidation in the left lower lobe, suggestive of periaspiration pneumonitis. An ultrasound pelvis was also done to rule out any source of sepsis from the uterus, and which showed no RPOCs post-evacuation. Oxygen requirements in this period fluctuated between 0.4 to 0.7%, and ventilation settings were optimized accordingly in the CCU. Patient was continued to work up along the lines of sepsis now, and antibiotics were upgraded to meropenem. Doxycycline was added to cover for any tropical fever, and later on, in view of persistent fever spikes, colistin was also added in the later courses, and I will show the graphs in the subsequent slides. So the CBC trend post-delivery, she delivered her fetus on the 7th of December. So post-delivery, despite any active bleed, her HB showed a falling trend. TLC initially showed neutropenia with toxic changes on peripheral smear, later stabilized. Platelet count again was low to begin with, but despite transfusions again remained to be on the lower side and did not quite pick up. LDH, the first report that we have, showed raised levels of 1500. Initially we thought it was part of the HELP complex, but later on we found out it was not quite so. So this is again the trend of the hemoglobin and platelets, and TLC, which initially the peripheral smear showed leukocytosis with reactive neutrophilic leukocytosis, and platelets were reduced. We had no other positive findings to work on in the beginning. With regard to her LFT parameters, before induction, her bilirubin was raised up to 3.7. But post-expulsion, there was a drastic rise in her bilirubin levels, which went up to 24 and later to 37 and up to 39, with the liver enzymes not correspondingly having such a bad course. They did rise moderately in between, but later normalized, and the coagulation profile was maintained throughout. KFT trend, she did have some amount of prerenal AKI, but she remained non-oliguric throughout her course and never required any hemodialysis. Fever, with regard to fever, immediately post-expulsion from 7th of December, throughout her stay in CCU, patient had continuous fever spikes despite antibiotics being administered according to culture sensitivity, which is why towards the later course of her stay in CCU, colistin was empirically added, but despite that she continued to throw fever. The subsequent cultures that was positive, the only other culture that came out positive on 12th was an ET culture, which again grew Klebsiella. All the other cultures, blood, urine, placenta culture, everything came out negative. So because all our workup was coming out negative and her initial suspicion of this case being a case of HELP with eclampsia did not quite improve post-delivery, we had additional workup being done simultaneously. Viral markers were done which showed HCV positivity with very low viral load. Autoimmune workup, whatever available in the hospital was being done, which was found to be negative. Fever workup was done simultaneously, again negative. Like I mentioned before, the only two cultures that came out positive was a urine culture initially which grew Klebsiella and an ET culture which grew Klebsiella and was being treated according to sensitivity. So here again we involved allied departments for help. Gastroenterology opinion was again sought because of the rising bilirubin levels. So they were again of the opinion that it is very unlikely because of a primary liver pathology, and we were asked to manage sepsis, and a hematopinion was sought for in view of bicytopenia. This is when the workup for hemolytic anemia was actively being done. And our first report, the peripheral smear showing schistocytes, was available on the 13th of December, which showed schistocytes of around 4%. And LDH at this point was 1800. So this suggested a picture of microangiopathic hemolytic anemia. And now our differentials widened a little bit from pregnancy-related causes, which were HELP or AFLP, or pregnancy-unrelated causes. So this is when we involved allied departments for HELP. Now, why this case? Initially, we thought it could be a spectrum related to eclampsia or HELP, because she did fit into the criteria of hemolysis, raised liver enzymes, and thrombocytopenia in a background of a pregnant woman in her second trimester. So this was the initial TD. And this is the most common thrombotic microangiopathy that we encounter in pregnancy. However, some points that very strongly went against this case being HELP was the timing of presentation for one. HELP is a disorder which is most commonly seen in third trimester or immediate postpartum, and they very typically tend to recover post-delivery, which was not the case in this patient. The deterioration was more profound post-delivery, which helped us rule out HELP and think of alternate disorders. AFLP again is a disorder, is again a life-threatening disorder associated with pregnancy, which can be associated with thrombotic microangiopathies. Again, rare, it occurs in 1 in 7,000 to 20,000 deliveries. But in this case, the absence of coagulopathy, any evidence of hypoglycemia episodes, imaging findings, any imaging findings pointing towards AFLP, nothing of this was available. And also, the treatment for AFLP also is delivery, removing the inciting fetus. In this case, again, deterioration post-delivery went against a diagnosis for AFLP. So this is when we involved hematology in the active management of this case, and they came up with the impression that this could be a case of TTP, thrombotic thrombocytopenic purpura, and we were asked to work up in lines of TTP. If I could invite Dr. Karthik from hematology to discuss how exactly they came up with this.
Thank you. A very good morning to one and all. And this case actually a very dicey case because this patient is a very young patient and a very early presentation, less than 20 weeks of gestation. So I just want to highlight a few points on this. What is this cystocytes and what is the thrombotic microangiopathy? And usually we see the thrombotic microangiopathy is a very big spectrum. It's not a very narrow spectrum, and usually the presentations are very, very dicey and very non-specific. So on any first instance, we cannot able to arrive at a diagnosis of thrombotic microangiopathy or a case of microangiopathic hemolytic anemia. So what exactly is this spectrum? This thrombotic microangiopathy, the name itself tells it is characterized by thrombosis, and this thrombosis is mainly because of the microangiopathy. What is this microangiopathy? Because of a platelet thrombus, RBC will go through the thrombus and it gets fragmented. So that is called cystocytes. So when we diagnose this TMA, we have to see whether patient is having MAHA. The underlying MAHA could be cystocytes. So it is the pathologist was the first point of contact, because on the examination of peripheral smear only we can identify the cystocytes, and unless we don't identify the cystocytes in the peripheral smear, I think thrombotic microangiopathy is almost very unlikely to be diagnosed. So it is characterized by presence of cystocytes, and patients will have a lot of hemolysis, and we see most commonly patients will have autoimmune hemolysis. This condition usually characterized by non-immune hemolysis. So we did Coombs test, so Coombs test will be negative. And because of hemolysis, patients will have high retic count. As depicted by the previous speaker, the retic count was 6.6, and patient didn't have any active hemorrhage also. And it will be characterized by a progressive increase in the indirect bilirubin and also a progressive increase in the raised LDH. And this everything is a non-specific marker. LDH, indirect increased bilirubin, increased retic count, everything will give towards the picture of hemolysis, and nothing when diagnosed with it's a thrombotic microangiopathy. So that's why it's a triad. Triad is like when patient is having a progressive decline in the evidence of hemolysis, which is non-immune, and there's a progressive decline in thrombocytopenia with evidence of the organ ischemia. When you have this clinical triad, then we suspect a patient could be having a thrombotic microangiopathy, not exactly like a TTP, HUS, HELP syndrome. We can't diagnose based on the clinical, this MAHA, thrombocytopenia as well as organ ischemia. So when we see this classification of TMA, the most common is always secondary, because the primary TTP, HUS, they are extremely uncommon conditions. So when we see the most common cause of thrombotic microangiopathy in this patient, the one could be as a pregnancy per se can cause thrombotic microangiopathy, and number two, preeclamptic toxemia, and the complication of eclampsia can cause thrombotic microangiopathy, and some infections, some subtle infections can trigger the underlying coagulation cascade, and they can predispose the patient to thrombotic microangiopathy. And number four is any connective tissue disorders like an SLE patient or a patient with scleroderma can also trigger a thrombotic microangiopathy. So for this patient, almost the secondary causes has been worked up, and it came to be negative for the secondary cause. When we take the primary cause, the most common could be Shigella diarrhea-induced HUS, and this patient didn't have any history of diarrhea per se. So Shigella HUS was ruled out invariably. Then the number two conditions could be a complement HUS or a TTP. So these two are extremely uncommon conditions. And when we see this classical graph, it's the classical triad as well as the pentad of the thrombotic microangiopathy, HUS and TTP, fever, and patients will have hemolytic anemia in this patient, thrombocytopenia, and AKI, and fever and neurological symptoms. She had evidence of fever which was not responded to any parenteral antibiotics, and she had a worsening neurological symptom. She came with seizures, and she was in persistent poor GCS despite aggressive management, and she had a progressive decline in hemoglobin as well as the platelet count. But in the part of AKI, for even the patient was admitted for last 14 days, she never had a single cessation of hemodialysis. That is more favoring towards a TTP, because a patient who has an HUS invariably will require an urgent hemodialysis. But this patient never had a single episode of hemodialysis, so that is favoring TTP more than HUS for us in this patient. So when we see the various thrombotic microangiopathy during pregnancy, no TMAs are common in first 2 trimesters. So we less than 20 weeks of gestation, we hardly see any thrombotic microangiopathy, because the pathway of pregnancy, hemostasis, the increase in factors, increase in coagulation proteins, everything occurs during the late trimester for the prevention of postpartum hemorrhage. For the prevention of postpartum hemorrhage. So when we see the first 20 weeks, TMA is very uncommon. But if first less than 20 weeks, if TMA occurring, then TTP will be the most common cause of a thrombotic microangiopathy, because less than 20 weeks, the only TMA occurs is TTP. And as the pregnancy progresses, then comes the most common causes, preeclampsia, HELP syndrome, fatty liver of pregnancy. And same TTP HUS will be continuous throughout the pregnancy, but more often in the 3rd trimester. So less than 20 weeks, we usually consider TTP as more common, because there will be early alteration of the hemostatic pathway in the pregnant lady. And when we see what are the common differentials, these are all the following differentials we can get in mind: preeclampsia, HELP syndrome, TTP, HUS, and even patients can have acute DIC, because with this patient also concomitant sepsis, Klebsiella pneumonia, as well as increase in procalcitonin. So preeclampsia, HELP syndrome, TTP, acute systemic vasculitis, usually common in rheumatological patients, and acute DAC. Everything can occur in pregnancy. But the thing is, usually preeclampsia, HELP syndrome goes towards the later of the pregnancy, so around third trimester. So this patient less than 20 weeks, so as or more than 72 hours postpartum, if patient is having worsening hemolytic anemia and worsening neurological status, we unlikely consider preeclampsia and HELP as a possible diagnosis. And number two, what is the lab parameter which is specific for HELP and preeclampsia is increase in the liver enzymes. So this patient doesn't have a marked increase in the liver enzymes because we expect a liver enzyme to be a more hallmark, but she didn't have a more increase in liver enzyme, whereas she had an LDH which was sky high. LDH was around 2000. So in TTP, when we see the laboratory parameters, there will be severe thrombocytopenia, platelets less than 25,000, 30,000, and LDH will be very markedly high, like in this patient. And AST-LC rise will be very less, and this patient also had an AST-LT of around 100s to 200s. And TTP, we can consider strongly in any trimester in pregnancy, and that almost the only DMA in the first trimester occurring is the TTP, and number two, it usually increases as the pregnancy prolongs, as over a third trimester, or even after delivery also, if patient is having worsening neurological symptom unexplainable with severe thrombocytopenia, hemolytic anemia, then we can consider the TTP. But still it is a very unknown, very uncommon cause. We cannot keep as a first differential always. And number third is a sepsis. Sepsis is a very wide spectrum. So patients can present with mild thrombocytopenia because of mild infection to a life-threatening severe coagulopathy characterized by abnormal in the coagulation parameters. So sepsis is always a back of the diagnosis, and usually sepsis always triggers all the underlying coagulation pathways like TTP, HUS. So sepsis cannot be ruled out anywhere in any patients. So what is the diagnostic dilemma in this patient? Symptoms are always non-specific for any thrombotic microangiopathy. And number two, usually TTP, HUS, on all the thrombotic microangiopathy incidence per se is very rare in all the patients. When we see the preeclamptic toxemia and HELP syndrome, out of 1,000 pregnant ladies, 5 to 6 can have PET or HELP syndrome. Whereas if we see the TTP, the incidence out of 10 lakhs, hardly we find 1 or 2 patients with thrombotic thrombocytopenic purpose. So it's extremely uncommon condition, and symptoms are also non-specific. But what's the problem with the TTP HUS? Unless we don't make a diagnosis, almost there will be 100% fatality. All the patients will have an 100% fatality because the treatment and the line of management will be completely different than compared to the thrombotic microangiopathies. And as we the classical pentad which I showed, fever, neurological symptom, anemia, thrombocytopenia, and uremia, this classical pentad is now extremely uncommon to see. So we can't wait for all the 5 parameters to be seen. When we see the 5 parameters, patients will be almost landing up in mortality. So what is the thing? Whenever we suspect itself, we have to start the patient on therapeutic plasma exchange, and there is no harm in giving therapeutic plasma exchange because since it's a life-threatening condition with 100% mortality, doing a 1 or 2 session of with the therapeutic plasma exchange is not going to harm the patient, and it will give us a prospective challenge also. If patient improves with therapeutic plasma exchange, then we can think a TTP a strong possibility rather than waiting for all the investigation to come at a diagnosis. So now with the above picture, this patient had a progressive neurological worsening. This is mainly because of organ ischemia, mainly because she had multiple clots in the liver, clots in the brain, causing progressive worsening jaundice and progressive worsening neurological status. And increasing bilirubin is further added by the evidence of severe hemolysis. And the fall in hemoglobin and platelets is because she is having first an ongoing microangiopathy, bloods are going consumed in the arterial level, so more breakage of the RBC and more consumption of platelets characterized by microangiopathy. And this is everything is diagnosed by the presence of a cystocyst in the peripheral smear. So unless we see cystocytes, this whole spectrum of TMA will be undiagnosed. Now, what is the treatment strategy we followed for this patient? We told them because we need to optimize the hemoglobin, obviously, for the patient to maintain a good hemoglobin level for managing the hypoxia because she has been mechanically ventilated. And platelets are absolutely contraindicated because once we keep on transfusing platelets, all the platelets will be consumed for the clot formation. So patients will have a worsening microvascular thrombosis, worsening jaundice, worsening neurological status. So we told it's better always to withhold transfusion unless patient is having a clinically evident active bleeding. This patient didn't have any episode of clinically evident active bleeding, so platelets were contraindicated. And always when we have a clinical doubt, because this patient didn't have any underlying coagulopathy, APTT, fibrinogen, everything was normal. But a single fresh frozen plasma as per the body weight can be given just because plasma contains lot of ADAMTS13, and this is the defective protein which occurs in the TTP. So when we give an FFP, even if we don't have a diagnosis, even we don't have a setup where we can do therapeutic plasma exchange, so we can give a fresh frozen plasma because this is a life-threatening condition, 100% mortality. I know the components of plasma per se can cause a lot of complications like trally, viral transmission and fluid overload, but this is an extremely life-threatening condition, so we take a risk and we have to go for the FFP transfusion. So we are given the FFP transfusion for this patient, and this will add on the ADAMTS level in the blood, and this can help in managing the TTP per se for a shorter period of time. And once the FFP was given, the next day when we saw there was a mild improvement in the neurological symptom in this patient, she was having a good she was having a better sensorium as per the assessment given by the CCU team. Since she was improving with fresh frozen plasma transfusion, then we approached our transfusion medicine department. Let us try the patient for therapeutic plasma exchange. So the Department of Transfusion Medicine also now started the therapeutic plasma exchange for this patient, and it will be further discussed how they started. And after the one session of therapeutic plasma exchange, she had a dramatic improvement. She was extubated from the mechanical ventilator, and she was having a normal platelet count and no evidence of hemolysis. And simultaneously from our side, we put the patient on a low dose methylprednisolone because it's an auto-antibody condition. So we gave a low dose because patient also having underlying active infection. And we continued low dose for a shorter period of time along with therapeutic plasma exchange. So this has worked for the patient. And we also considered the early rituximab therapy, but the patient could not afford. And rituximab per se is not going to do any magic in the first 1 to 2 weeks of therapy because it will take its time over the due course, and is mainly given to reduce the number of recurrent relapses in the TTP. So a few points on TTP. What is it? It's a life-threatening TMA where this ADAMTS13 protein, it's a main important cleaving protein which will cleave the wall Willebrand factor. So it will be in a shorter state. If there is no ADAMTS13, VWF will keep on building and they keep on attracting lot of platelets, and these platelets as well as the von Willebrand factors will causes the microthrombi formation and causes the underlying all the pentards of the TTP. So it's 99.9% an autoantibody condition to ADAMTS13. There is only a 0.1% chance of a congenital absence of ADAMTS13. That's why the guidelines always start the patient on immunotherapy like steroids or rituximab because it's 99.9% autoantibody condition. And so this is a normal peripheral smear where we can see the RBCs of discord are round in shape, and we can see a lot of platelets are in clumps. So this is a normal peripheral smear obviously, but this patient, in this case, there are a lot of fragmented RBCs. The patients will be having a lot of fragmented RBCs, and we hardly see any of these violet color platelets in the peripheral smear. So when we see even more than one fragmented RBC in the peripheral smear along with the no platelets, so the pathology will give us given suspicion of the patient could be having an MAHA. So based on this, there will be a lot of differentials which will be arising. So there is a score which is available online, and that will predict what is the percentage of probability of a thrombotic thrombocytopenic purpura. And we usually calculate this most famous score called the plasmic score. So based on this score, we will take a call whether the patient is less likely of TTP, then we won't do FFP or a plasma exchange. When there is an intermediate or high risk of TTP, then always it's better to start the treatment rather than go for ADAMTS13 evaluation. So for this patient, we approached Christian Medical College Vellore. They took a very big step in doing the ADAMTS13, and we took the sample and cryopreserved in blood bank. But because of financial constraint, the sample is still in blood bank, and we could not able to send the ADAMTS level 13 to CMC Vellore. And when we see the treatment per se as a flowchart, when we suspect TTP, when there is an high probability test of like for example patient high plasmic score, start empirically therapeutic plasma exchange as well as start on low dose steroids. Even if ADAMTS13 is not available in our institute or in anywhere, start on TP as well as steroids. If we can send ADAMTS13 activity within the first 1 week, then you send the level, and once it comes positive, then we go on for the specific targeted agents like capalizumab. This is a specific targeted agent, is usually not available in India. Otherwise, a normal TPE plus a low dose steroids plus or minus rituximab to prevent the future relapses is more sufficient and has an almost more than 80% cure rate, and all patients can be salvaged with this TPE and steroid therapy. Thank you. Now I would like to invite the next speaker from the Department of Transfusion Medicine.
So after the hematology team made the diagnosis of TTP, our team was involved for therapeutic plasma exchange. So now apheresis, this word is derived from the Greek word apheros, which basically means to take away. What we do with therapeutic apheresis is we take away the pathogenic blood components of the patient, and we return the normal blood components of the patient back to the patient. Now this removal could be by the use of either a filter or via centrifugation. Now centrifugation, it works on the principle that different blood components, they have different specific gravities. For example, plasma, being the lightest, has a specific gravity of 1.02, whereas RBCs, which are the heaviest, they have a specific gravity of 1.085. So based on that, we can selectively remove the components that we desire from the patient and return back the other components to the patient. And now in therapeutic plasma exchange, what we are doing is we are exchanging the patient's plasma with a suitable isotonic replacement fluid. So here this diagram shows the procedure of plasma exchange. As we can see, the blood from the patient is being pumped into the centrifuge. Now over here we use the centrifuge equipment that we use over here is spectroptia, which is shown over there. So the patient's plasma is removed and it goes into the waste. And after that, the patient's own red cells are pumped back into the patient with the addition of a suitable replacement fluid, in this case, the plasma. So what is the rationale behind performing therapeutic plasma exchange in the patient of TTP? Basically, TPE removes the autoantibodies and it also replaces the diminished levels of ADAMTS13 activity. Now, there should be a low index of clinical suspicion in these patients. Like, we shouldn't delay the treatment. As soon as there is a clinical suspicion of TTP, initiation of the treatment should be within 4 to 8 hours. Since the mortality can be as high as 90% in these patients. So we want to reduce the mortality, as clinical trials have shown that the mortality reduces to less than 10 to 20%. So that's a huge reduction in mortality. If we are anticipating any delay in starting TPE, what we can do, it is recommended to start FFP at large doses, at 25 to 30 ml per kg in these patients. Now, when we received the request for performing therapeutic plasma exchange in this patient, we did a clinical assessment, obviously, and she had a very poor GCS. Apart from that, on calculating the plasmic score, she fell into the high risk category. As you can see, she scored 6 on the plasmic score. So we planned for taking the patient immediately for a therapeutic plasma exchange. So these are the patient values that were present before the first TPE procedure. So when we deciding whether to take a patient for therapeutic plasma exchange, we use the guidelines given by the American Society of Apheresis. Now, this is an evidence-based guideline which basically categorizes the indications of therapeutic apheresis in the patients, with category 1 being a first-line therapy. Therapeutic plasma exchange would be a first-line therapy in this patient, and the recommendation 1A basically stands for strong recommendation based on strong evidence like clinical trials, and it is recommended to perform daily TPs in TTP, and 1 to 1.5 plasma volume of the patient should be processed and exchanged, with the replacement fluid being plasma in TTP. In this patient, we performed 3 procedures. The first procedure was performed on day 9 of admission, which was on 14th of December. We did a 1.5 volume exchange, and we used a mixture of fresh frozen plasma and cryopoor plasma. The second day, we did a 1.2 volume exchange, followed by a 1 volume exchange. Now here, this picture shows the plasma of the patient during the first TPE procedure. As it is visible, it is very high colored, and this is the patient's plasma during the third TPE procedure. As you can see, the color is almost comparable to the normal plasma. And here, this is the circuit of the TPE where we can compare the patient's plasma, which is pretty high colored in comparison to the normal donor plasma. So, as per guidelines suggest that the discontinuation of TP should be done when there is resolution of neurological symptoms in the patient, and the platelet count is more than 150,000 per microliter, and LDH has been near normal for 2 to 3 consecutive days. In this patient, we did 3 procedures because after the 3rd procedure, the patient had substantially improved. After the very first procedure, the patient had a very dramatic improvement clinically. So before the first TP procedure, she had a very poor GCS and she was intubated. Within a few hours, she could be extubated on the same day. And before assessing her for the second procedure, we saw that the patient was obeying commands, and she was slightly confused, but she was able to obey commands. And after the second procedure, that is on the 3rd day, she was completely normal. She was so it was a very dramatic improvement actually. Now these are the blood parameters after TP. So as we can see, there's a rise in the hemoglobin levels as well as the platelets, and the LDH has fallen substantially as well as the bilirubin levels. So if we see it specifically, because LDH and platelet parameters, they help us in deciding when to discontinue TP. So as we can see, before the start of the first procedure, it was the LDH was 1870 units per liter, and then after the first procedure it was 110. After the second procedure, it fell to 414. There was a slight rise after the 3rd procedure, but overall, before the patient's discharge, it had stabilized to near normal levels. And the platelet count, this is the most, it improved drastically. So the patient, when she presented on day 4, she had a platelet count of around 20,000. After platelet transfusions also, before the first TP procedure, she had 34,000 counts. And this rose to, after the first procedure itself, it rose to 84,000. And after the 3rd procedure, it rose to 2,21,000. And before discharge, on the day of discharge, she had a count of 4,97,000. So that was a very dramatic improvement in her platelet counts. So after 3 sessions of TP, she was shifted back to the ward in stable condition, and then the neurology and gastroenterology team took over.
Good morning everyone. I will be discussing some ICU specific concerns. So ICU admission of the patient, in any patient with TTP, they can come due to severe organ dysfunction. So the organs involved are brain, kidneys, heart and the GIT. So in this patient specific organ involvement, there was first neurological involvement. Patient presented initially with seizures. So with initial imaging showed MRI changes which was predominant of breast. Breast changes are most common finding even in TTP. Breast is also seen in eclampsia patients. This is also a finding in TTP. So that is a like overlap in diagnosis. This was there. Another brain ischemic symptom. The seizure could have been due to the brain ischemia symptoms. There was some micro hemorrhages that can happen even in this kind of patients. So other part is that AK was not severe. Mostly in patients with TTP, the creatinine doesn't rise more than 2, which was seen in this patient, and renal replacement therapy was also not required in this patient, which is also favoring a TTP diagnosis. Apart from that, there was a lung involvement which is not reported in any patients of TTP. This patient had a pneumonia, maybe because of she has gone to 2-3 centers with an altered sensorium. She could have aspirated there, got an aspiration pneumonia there, and presented here. So that could have been an add-on diagnosis apart from TTP thing. So because of these things, she had low platelets. She had in the initial presentation, she had repeated ET bleeds for which there was a partial tube loss, tube changes, and oxygen requirements were fluctuating from 40 to 70%, for which the ventilation strategies were optimized. So in a review of literature, there were 6 studies of critically ill TTP patients. So in that, lungs were never involved. The requirement of ventilator assistance was due to either the neurological low sensorium or a hemodynamic failure. Primary lung parenchymal thing was not commonly involved. There are need for renal replacement therapy in this study was like 0 to 19%. The hospital mortality was 4.3 to 34%. In patients who were diagnosed and treated, the mortality was less than 10%. But in whom the diagnosis was not made or the diagnosis was delayed, the mortality was as high as 80 to 90%. So most of the common indication for ICU admission in these patients are, most common indication is the organ dysfunction. Apart from that, these patients have severe thrombocytopenia, risk of bleeding is there. So during PLEX there is a requirement placement of a central venous access. In presence of profound thrombocytopenia, safe placement of central venous access is the most important thing. Risk for bleeding is there. So we have protocol of doing it under USG guidance, so this complication can be avoided. So the other thing is the rapid initiation of PLEX under a monitored area. So plasma exchange is available in-house in ICU, so that we were able to initiate the plasma exchange as early as possible. And some patients most patients may present like sepsis. Like this patient, we had an initial diagnosis of eclampsia bar sepsis causing the worsening of symptoms. In this study, they have found that almost 40% of the patients admitted had a diagnosis of TTP who were initially admitted in lines of sepsis. So this is just a summary of statement on ICU management. So all patients with suspicion or a diagnosis of TTP should be admitted to the ICU for early PLEX initiation or for any supportive organ support which is failing. So in some patients where the resources may be limiting, the patient may be admitted at a later stage into the ICU. So this may be due to a refractory or relapsing TTP, catheter related complications like bleeding, infection, thrombosis, transfusion related reactions, or sometimes there may be a worsening in general condition even after plasma exchange. And especially pregnant patients with TTP should be admitted as early as possible. So time to discharge should be decided based on the response to treatment and the resolution of organ failure. So there were some, in one review they have quoted the factors which can be associated with poor outcome. This patient was lucky because the diagnosis and treatment was available in a timely manner. So these are some poor prognosticative factors. One is the age more than 60 is one poor prognostic factor, but this patient was in the 20s, so that is favorable outcome. Cardiac troponin elevation, this patient didn't have any cardiac involvement, so that is favoring a good prognosis. CNS involvement was present in terms of seizures, altered sensorium. Even after extubation, patient had a component of delirium which was subsequently managed in ICU and then shifted to ward in full conscious state. So delayed diagnosis is one of the most predicting factor to have the outcome. So they have pointed out that cystocytes may not be seen initially. So in the entire review also they have found this. So in our case also the cystocytes was not found in the initial first two peripheral blood smears. Only in the later smears we were able to pick up the cystocytes. In another overlap can be that DAT may be positive, but our case DAT was negative. So reticular site response may be delayed. So later only reticular site had 6% in our case. So another thing is platelet transfusion may worsen the clinical deterioration, but in our case we have to transfer platelet because there was active ETB, so that we cannot avoid. And LDH elevation, so in our patient we had a improvement in LDH. The trend was towards decreasing LDH levels, but there are some cases where the LDH can remain elevated even after therapeutic plasma exchanges, so that is one of the indicator of poor outcomes. Some patients will be refractory. They will be refractory to initial therapies. The initial therapies are the plasma exchange and steroids. So later on, second line therapies can be given. Even then, if they are refractory, then the outcome will be poor. And recurrent diseases, they can be fatal. So this patient are most likely a first presentation, and ethnicity and other risk factors like cardiac arrest, pancreatitis, they are poor prognosticating factor for poor outcome. This patient was lucky enough to get the timely diagnosis, timely treatments in relatively resource limited settings. Thank you. Gayatri can give a summary of take-home lesson.
Thank you. Thank you, Dr. Karthik sir, Dr. Prasanna sir, and Dr. Zafar for the very useful info. And this case was very interesting in the case that multidisciplinary approach from the very beginning led to the very favorable outcome. And